another topic that is a futuristic topic, and a topic that every one of us would love to hear for ourselves, and as well as for our patients. And we have none other than the master of publications on this topic in India, Dr. Sanjay Kalra. And there is a wonderful team with him of experts, Dr. Nitin Kapoor, Dr. Rakesh Sahay, and Dr. Meenakshi Dhar. Uh, are those 4 lines also on his slide required to introduce Dr. Sanjay Kalra on this forum? So, sir is not only an extremely well clinician, researcher, academician, a wonderful speaker, and a wonderful teacher. So, on Teachers' Day, I thank you, sir, for everything that you taught us. And I hand over the mic to you to introduce the panel first and then go ahead with the topic.
Thank you, Dr. Anjali, and thanks to the organizers for this wonderful opportunity. Like you said, this is a really important topic. All of us have been young, we have been adolescents, but that was in the past. All of us are aging, that is in the present. All of us will age, that is in the future. So it makes more sense to speak about this topic. I was really impressed by the discussion in the previous masterclass, where we spoke about adolescent medicine, adolescent diabetes, where we spoke about reversal of diabetes. And the message that came across was you should give hope to your patient. The patient should have the opportunity to talk about the possibility of remission of diabetes. That's why we should also have the opportunity to talk about remission of aging or postponement of aging. For this, we have a wonderful team with us. We have Dr. Nitin Kapoor, who is Professor of Endocrinology at CMC Vellore. He is also a PhD and a faculty at Melbourne in Australia. We have Professor Rakesh Sahay, who is Professor and Head of Endocrinology at Osmania Medical College in Hyderabad. And we have Dr. Meenakshi Dhar. Madam is Head of Department Medicine at All India Institute of Medical Sciences, Rishikesh. Madam teaches not only internal medicine students, but also geriatric students. And that is her special area of interest, geriatric medicine. Dr. Dhar is also spearheading, along with Dr. Nitin, a new definition on sarcopenia. Now, let's talk about aging and let's talk about why it's important. A warm welcome to Dr. Nitin, Dr. Rakesh, and Dr. Meenakshi. If we look at history of humankind, for the past 200 years, actually our lifespan has been going up. In the last 200 years, it has doubled. There are people who say that we have reached the limit. There is a biological or a biomedical limit. Beyond this, we cannot grow older. But this has been raised many times in the past as well, over the past 100 years. And each time, researchers said that now we have reached a limit. People proved them wrong. Different countries proved them wrong. As of now, the world record for maximum longevity in both men and women stands with Japan. But there was a time when it stood with Sweden. So there is dynamism there as well. And you never know, in the years to come, it might be India which holds the world record for maximum longevity. With this in mind, let's look at the future. Let's see how we can actually prevent aging. But Dr. Meenakshi, before we prevent aging, can we talk about aging? What is aging? Is it physiological? Is it pathological? And how can we measure it? Is it just a calendar age or is it something else that we can measure?
Yeah, sure, Dr. Kala. Thank you. Thank you for giving us this opportunity to discuss about this topic. I mean, and seeing that endocrinologists discussing this topic, it's really of, it really tells that we have definitely a bright future, and maybe the India will top the list of centenarians now on. So should I share my slide?
Yes, please.
Is my slide visible? No. Have you stopped sharing, sir?
Not yet. I'm not sharing.
Ma'am, can you try sharing again?
Yeah, right.
Yeah, you are sharing, but you
actually
you have to select this presentation.
Yes, PowerPoint window.
Yes.
Rather than the web window.
While Madam is doing that, when you're trying to assess aging. There are many ways of doing it. Of course, Madam will speak to us in greater detail, but let's look at hormones. Now, many of us would say that estrogen or testosterone are ways of assessing aging. But see how it works in endocrinology. Let's say you're talking of insulin. We speak of insulin sensitivity, insulin resistance, and we know that this concept has limitations. So we speak of the insulin glucagon fulcrum, and we speak of relative insulin levels, relative glucagon levels. And that makes it much easier for us to understand the pathophysiology of diabetes. It also makes it easy for us to understand how we have to manage diabetes. Similarly, in aging,
Shall I?
like I said,
Madam is having a problem. Shall I share her slides? Yeah,
you
she got it.
can. It's come. Perfect.
Is it coming?
Yeah.
Yes. Now slide.
You
So
just need to go to one.
perfect.
Is it coming?
Perfect.
Thank you. Thank you for sparing some time. It always happens most of the context here. Thank you, Dr. Kalra. And so what I'll be discussing, as Dr. Kalra has already introduced my topic, that I'll be discussing this geriatric in nutshell. So we'll be with the learning objectives of, we'll define age, what are the theories of aging, what is chronological versus biological aging, the factors which affect aging and types of aging, and how do we assess aging. So what is aging? Aging is normal developmental event and relates to maturation of an organism. It begins with conception and continues throughout the life until we die. But some argue that the development begins at conception and we age only after 30 years. Whatever happens, one thing is sure, that aging is progressive and inevitable. Goldmere was the first female prime minister of Israel, and she became prime minister at the age of 80 years. According to her, she said that old age is like a plane flying through a storm. Once you're aboard, there is nothing you can do about it. This shows a unifying model of aging. As the person ages, the body composition changes. There is discrepancy in the energy level and production. There is hemostatic dysregulation and neurodegeneration sets in. All these lead to increase in the disease susceptibility, reduced functional reserve, reduced healing, and they all lead to frailty and failure to thrive. Because of these changes in the physical domain, there is development of what we say the geriatric syndromes, like there will be gait abnormality, there will be anorexia, malnutrition, urinary incontinence. But believe me, these are the geriatric syndromes, are not the diseases, but they are the conditions which make this population unique from others. Even though it has been argued that aging starts at birth, but it is well known that the 5 to 10% of the decline in body functions occurs only after 30 years of age. And the main systems which affected are the respiratory, cardiovascular, renal, and the nervous system. Whatever changes can occur in bodies does occur in body system. All these lead to some common characteristic features, and they are like there's increase in mortality, there's biochemical composition of the tissue changes, physiological capacity decreases, ability to maintain the homeostasis diminishes, and susceptibility and vulnerability to disease increases. There have been various theories which have been proposed, but the main aim of the theories, they address the two questions only. The one is, why do we age? And the other theories which address the question, how do we age? Over the time, some theories have fallen out of favor as others have become more accepted. So initially it was said that the one is the psychological theory of aging. Among the psychological theory, it is said that disengagement theory is the one because of which the person ages. It says that it's a process through which society and individuals gradually withdraw or disengage from each other. Then there is activity theory. It is said that the individuals who engage themselves in their continue their active life throughout during the old age also, they age slowly. Then there is continuity theory, that those people who maintain their relationship during the older parts of the life as they had maintained during the younger ages, they also age very slowly. Then there is social exchange theory, which says that more the people remain socially active, the less they age. After this, we have some people suggest that there is an external environment which affects the aging. So when there is excessive exposure to sun's radiation, which puts the skin at risk during somatic mutation and results in aging. According to Perlman, human aging is a disease syndrome arising from struggle between the environmental stress and biological resistance and the relative adaptation to the effect of these stressors. These stressors might be air pollution, chemical, psychological, or sociological events as well. Then there is developmental theory of aging. Erickson theorized that person's life passes through 8 stages, and each stage represents a crucial turning point in life, stretching from birth to death, with its own developmental conflicts to be resolved. Taking this concept forwards, there was a Roman philosopher, Kirko, in 44 BC, who wrote a book on old age, and he said that old age is the final act of life we ought to leave when the play becomes worrisome, especially if we have had our fill. Probably the concept is same as we have in our ancient literature, which suggests that human life passes through 4 phases, that's brahmacharya, grahasthashram, vanprasthashram, and sannyasashram. And the one who follows these ashrams genuinely and religiously lives dignifiedly and has a dignified death as well. Now coming to the modern biological theory. Here we have programmed theories and damage or error theory. The programmed theory follows a biological timetable and depends on the gene regulation that affects repair and defense responses. Whereas damage or error theory emphasizes on environmental assaults to living organisms that induce cumulative damage at various levels and causes aging. In programmed aging theory, we again have programmed longevity theory, which says that aging is the result of sequential switching on and off of certain genes, with senescence being defined as the time when age-associated deficits are manifested. Here, they have given the two theories, that is antagonistic pleiotropy and telomere shortening theory. Among the programmed aging theory is the endocrine theory as well, which should interest the endocrinologists. It says that the biological clock acts through the hormones, and it has been seen, the research has proved it, that the hormonal pathways play a very significant role in the development of the aging, especially the sarcopenia. Then we have immunological theory, which says that immune system is programmed to decline over time, which leads to increased vulnerability of infectious diseases and thus aging. This can be corroborated with the fact that immune system is robust during the puberty times, and it starts declining as the person starts aging. Among the damage and error theories, we have wear and tear theory, which is still acceptable, and most of us believe still in this, is that the cells and tissues have vital parts that wear out as a result of aging. This we can compare it with an worn out shoe, which on repeated use gets worn out. In the same way, the body cells and tissues wear out with the repeated use and ultimately die. Then we have this rate of living theory. This says that the greater an organism's rate of oxygen basal metabolism is, the shorter is the lifespan. I remember that when I was a child, my dadi, who was an illiterate woman, she used to tell me that if you want to live longer, you breathe slowly. So then there comes the cross-linking theory. It says that accumulation of cross-linking proteins damage cells and tissue, slowing down bodily process, resulting in aging. And research has shown that the cross-linking reactions are involved in age-related damages or changes in the studied proteins as well. Then we have a free radical theory, which says that superoxide and other free radicals cause damage to the macromolecular components of the cells, giving rise to accumulated damage, causing cells and eventually organs to stop functioning. Then we have a somatic DNA damage theory, which says that DNA damage occurs continuously in cells of living organisms, and aging results from damage to the genetic integrity of these cells. If you are most of us, when asked how old you are, your answer will be based on how many candles were you on your last birthday cake. But after coming across so many theories of aging, will it be right to mention just the number of years have passed since your birth? No. So chronological age is not a very good indicator of how well a person might be aging. Two individuals born the same year might have different risks of developing certain age-related conditions because they are aging at different rate. That's why you often see a person who appears and acts younger than its really chronological age is. That means that a chronological age is measured in years, but the biological age is assessed by person's physical and mental function, which is influenced by a lot of factors. There's a linear correlation between the biological age and the chronological age, and the slope of this relationship depends on various factors, various environmental and genetic factors, and diabetes being a very important factor which determines this slope of this linear graph. The other factors which are involved apart from the genetic factors in determining the age are the diet and the nutrition, the exercise, the exposure to environmental toxins, the chronic conditions like diabetes, and so on. So in nutshell, if we want to define an old age, it's nothing but the garbage which one collects when they are young. So important thing is what you collect, that will determine how you age. Staying healthy isn't just how old you get, it's about how you get old. According to Paul Sender, who chairs the genetic department at Stanford University in California, he discovered body ageotypes. So what are these ageotypes? These are specific ways in which certain people age. People with different ageotypes grow differently over the course of their illness, experiencing aging according to distinct patterns. These create very distinct profiles, which can tell someone an enormous amount of how their body will change over time. And perhaps more importantly, these profiles tell how people can take care of themselves as they grow older. As of October 2020, Sanders' team has identified 4 different ageotypes. For one is the metabolic ageotypers, the other are those people whose immune system ages faster. They are called immune agers. Then there are people whose kidneys age faster. They are nephrotic agers. Then there are people whose liver ages faster. They are hepatic agers. Take for example a 45-year-old female who's chronologically 45 year, and she has a liver of a 55-year-old person and a skin which resembles that of a 35-year-old female. So even though she has celebrated her 45th birthday and burnt 45 candles on her birthday cake, her median age for her liver is 55 years and skin resembles that of a 35 years. So these effects are often the result of the lifestyle choices by the individual. It's like a car. If you buy a car, it gradually wears out over time, but some parts wear out faster than others. Isn't it true? So what is the implication? Why is it important? A classic immune ager might be chronologically 40 with the immune system of 42-year-old and a metabolism that is biologically 32. This person would likely remain more slender in old age, but would also be increasingly prone to immunocompromise and related conditions over the course of their life. This is against a person who is a metabolic ager, on the other hand, might retain a healthy immune system while increasingly struggling with diabetic risk factors and weight as they grow older. Why are these ageotypes important? Right now, our medical system is totally broken. At so many different levels, we are very reactive. The best example is what we saw in this COVID pandemic era, where everybody was rushing towards discovering a wonder drug, doing so many trials and do so many experimenting to treat this COVID infection. We work on people when they become sick, but we really don't focus on keeping them people healthy. And this is especially true in terms of geriatric patients, because West has realized that treating a geriatric patient is really a very troublesome thing, and we as a developing nation cannot probably afford it. So we have to stress more on the preventive aspects of it. So here lies the answer. Like most of issues surrounding health, ageotypes are based on the combination of genetic predisposition and lifestyle choices. So if behavior can help accelerate aging, so it can also help to slow it down. The holy grail is being able to use this information actionably, identify the ageotype and suggest program that might improve what people are doing. So if they are metabolic ager, exercise and food would be the answer. This personalized and proactive approach will make big difference in allowing people to live longer and a healthier life. Now we know that determining biological age is really a better measure of aging and how a healthy person is. So how to measure it now? We can measure it by epigenetic clock, or we can measure it by telomere shortening. As regarding the telomeres, I had already discussed during the theories of aging. Now, recent research points to the importance of DNA methylation in health and aging, and it shows that the environmental and biological factors affect this methylation process. Researchers have also found the correlation between the aging of different bodily tissues and the extent of DNA methylation, known as epigenetic clock. So, measuring the methylated DNA can give an estimate of a biological aging. Another age and health related biomarker is telomere length. Telomeres are proteins on DNA found at the end of the chromosomes. They are responsible for protecting the DNA structure and function. Shorter telomeres are associated with poorer health and greater biological age. So, measuring telomere length can give an estimate of a biological age. To sum up, for measuring the biological age of a person, scientists have proposed a lot of molecular and functional and structural biomarkers. There may be some invasive and non-invasive techniques as well. Apart from telomere and measuring the methylated DNA, there are somatic mutations, there are inflammaging age markers like interleukin 6 and CRP, insulin-like growth factors, growth hormones, LDL, and then there are non-invasive techniques like measuring the arterial stiffness, the blood pressure, endothelial dysfunction, intimal thickness, atherosclerosis, calcification. Apart from this, there are composite biomarker predictors like vascular aging index and frailty indices, which help us to assess the biological aging. Apart from this, there are many computers, the calculators available on the net, wherein we put our biochemical parameters and they calculate us our biological age. These how authentic they are, not very sure, but they are available on the net. So many things have been talked about aging, and my colleague is going to discuss various ways to retard it as well. But I wish to close my presentation with this question: who is old? Anyone who stops learning is old, whether at 20 or 80. Anyone who keeps learning stays young. The greatest thing in life is to keep your mind young. And participating in these scientific sessions will definitely keep all of us young. Thank you.
Sir, if you could unmute yourself. Dr. Kalra, you are on mute, sir.
You can classify your patients according to agiotypes as those who age with regards to their immune system, their hepatic system, their kidney, or the metabolic system overall. Of course, there will be overlap, but this is a nice way of assessing all patients.
Yeah, there will be overlap, and the one person may have, it's not that he will be only hepatic agers. He may be have hepatic plus renal, he may be hepatic plus immunogenic. So there is an overlap, and many other systems may also be involved. But this is a way of identifying the people, how they are aging. Because once we identify these, how they are aging, then the lifestyle modifications which are proposed to be, one of the basic and cause for aging. So that is how we can approach these patients and make new technologies which can retard aging as well.
One thing that comes to my mind is that we speak of the biopsychosocial model of health. The World Health Organization also includes that. And recently I learned that in 2011, just about 10 years ago, the WHO actually added an erratum to its definition of health, where they said that there is no health without mental health. If we speak of the biopsychosocial model of health, we should also speak of the biopsychosocial model of aging. And so we can create an Indian agiotype classification, which is the 4 biomedical agiotypes that Madam has mentioned. Then you have a psychological agiotype that Madam alluded to, which is if you stop learning, if you think you are old, then you become old. So that is psychology. And from India, another important point of view would be the social agiotype, social stereotypes, where, like now, Dr. Rakesh Sai, he's president-elect of Endocrine Society of India. So he's expected to behave like an aged person. There is a social pressure upon him. So even if he wants to wear a flashy orange shirt, he cannot do that. So, Dr. Rakesh, what's your opinion about biopsychosocial model of aging, and how do we assess it? What can we do in terms of symptoms and signs and lab abnormalities? And once you've done that, we'll ask Nitin Kapoor to help you out by ensuring that you do not age.
Yeah, thank you, Dr. Kalra, and thanks to the IDEC team for giving us this opportunity. I'll actually, Madam has given a very good overview about aging. She has spoken about the different types of assessing aging and all that. So what I'll do is I'll quickly run through some of these things because these have been covered by her very nicely, so that I know there's enough time for Nitin to speak about how to prevent aging, because that's the more important part. Assessment has been I mean we have learned a lot about assessment. So what I'll try to do is that I'll do this quickly. So what madam has actually showed us is that when you're looking at aging, you're looking at several aspects, and she has shown the different pathways, I mean different ways in which your aging is manifested through frailty being a very important component in that. And then the various syndromes, she said you could have manifestations in various ways of aging getting manifested in different ways. And so what we are looking at is that we have several tests, as she spoke about the immunological phenotype. You can look at the immune system, aging of the immune system, immune metabolic aging, and the hepatic aging, the renal aging. So she spoke about so many of these various things. And we are looking at what could be a biomarker, what could be a good biomarker to identify these different aging in different systems. So just to say that we have a lot of data accumulated from various studies, like the Framingham study, the enhanced database, and also the MacArthur study. They have actually looked at biomarkers of aging. And so these different ones have actually, these different biomarkers have helped us in understanding what should be the a good biomarker for understanding the aging. So you could have biomarkers which are looking at the cardiovascular system, the metabolic system, the inflammatory system, as has been spoken of, the nervous system, the sympathetic nervous system, various organ functions, oxidative stress markers, all these, and also activity of the hypothalamic pituitary axis could also be assessed to understand aging, and these could be the biomarkers for aging. So if you look at the cardiovascular system, you have simple measures like the blood pressure, the pulse pressure, the resting pulse rate. So all these could be important biomarkers. As again, madam has highlighted the fact that people who have a lower pulse rate probably are the ones who are aging slowly. So those are all the biomarkers that can be used. And then you could have measured biomarkers, as you can see, the normal values or values which would indicate that these are the ones who are above this are probably aging faster. This is how we could use simple measures which are using in our day-to-day practice. We could use to understand how the aging is going on, and we could use even lipid parameters to understand the aging process that is going on. HbA1c, the waist to hip ratio, the leptin levels, adiponectin levels, all these could be used as biomarkers for understanding the process of aging. Now, again, we could look at the markers of inflammation, immunity, and infection. We could look at C-reactive protein, the IL-6, fibrinogen. So all these could be important markers to understand the process of aging. And we could look at various cut points that we are all aware of. So I'm not going into too many details of all these, but I'm just touching upon all these so that we understand how we could assess aging through various markers. Then if you look at the systems, CNS markers for aging, you could look at the amyloid proteins, the tau proteins, which are again very important proteins which accumulate in various conditions which could be associated with aging. They are all, again, these could be measured in the CSF and could be good markers for aging. You could look at the HPA axis and understand the process of aging through the measurement of all these markers in the blood, in the saliva, or the urine. And these are again the ones which we could look at. And then we have markers of organ dysfunction, like renal dysfunction, with measured by creatinine or even cystatin C, the peak expiratory flow rates, the EKG, and these could again be markers for understanding the process of aging. Then we could look at reactive oxygen species, the levels of superoxide dismutase. These are all could be important biomarkers for aging. Now let us look at some of the molecular markers. You have some molecular markers which could be used as was highlighted by Dr. Meenakshi again in her talk. She spoke about the telomere shortening and the epigenetic modifications that are happening. These could again be used as molecular biomarkers for understanding the process of aging. And the telomeres could be measured. The DNA repair can be assessed. The slowing of the DNA repair could be indication of aging. Epigenetic modifications in the form of hypomethylation could be a factor which could be used to assess the aging. The loss of histone proteins, histone modifications, these are again indicators of aging. And measuring the non-coding miRNAs. These are small non-coding mRNAs that through their base pairing mechanisms regulate a broad range of biological processes, including metabolism and aging. So they can be used as markers for understanding the process of aging. Then we could have other markers like ApoE, mitochondrial DNA, and also measuring the gene for angiotensin converting enzyme ACE gene, which we use in many situations. This could also be used as a marker for aging, as it has been shown in to be increased in Alzheimer's disease, and lower levels of this have been shown with human longevity. Then there are other interesting ones like what Dr. Kalra was speaking about. IGF-1 signaling can be assessed. The insulin sensitivity index could be another factor. The mTOR activity and the AMP kinase activity, which we are very familiar with, and Dr. Nitin is going to speak about all this in his talk. And also the levels of sirtuins can be used to assess aging. Aging actually causes downregulation of these sirtuins. And there could be other markers of protein catabolism, like the accumulation of age products. Age products are the glycosylation end products, which are again indicators of aging. And poor glycemic control over a period of time actually leads to accumulation of these age products, and again indicates a higher, faster aging. And so these are all the molecules, the age molecules, and other molecules of oxidative indicators of oxidative stress and mitochondrial damage could be measured in the form of these various molecules. I will not go through details of all this, but these are the various other molecules which could be measured to understand the impact of oxidative stress and mitochondrial dysfunction. Then we could measure the cell senescence through measuring beta galactosidase and all other markers like this, which could give us an indication of the cell senescence. So these are the various markers. Now coming to, moving away from that and understanding some of the simpler markers which we are all aware of, which we can measure. Phenotypical markers of physical function and anthropometry are also very important. And these should be combined with other markers biomarkers that we spoke of: walking speed, chair stand, standing balance, grip strength, body mass index, the waist circumference, and muscle mass are probably more simpler, easy to measure markers which could give us an indication of the aging process. And these physical measurements, which are very important, though very simple, can be actually performed better than the DNA methylation and other markers in terms of the relationship to the health status in demographic research. And these are things which we should not forget while we're looking at the other biomarkers. And a sort of amalgamation of both of them is probably much better. And there is what is called as quantitative phenotyping can also be done. You could look at facial features. They could be quantified by three-dimensional imaging, facial imaging, and that could help us in sort of understanding the biological aging of individual. Madam was speaking about the skin aging. That can be actually quantified by this type of a process that can be done. So we need to integrate all these multiple biomarkers and devise a system by which we could assess aging more effectively. And this could have several applications. This could have applications in terms of understanding the aging and probably help in reversing aging. So I would say that a proper assessment using the phenotypic markers and the biomarkers is going to be very helpful in understanding the process of aging, and this could help us in identifying strategies for preventing progression, which can be instituted early so as to have the best results. So with that, I would conclude here, and I'll stop sharing my screen.
Thank you, Dr. Rakesh, for that. So perfect continuation of what Dr. Meenakshi began with. She began by describing aging and created different agiotypes for us so that we can understand the different verticals. This is quite similar to how we understand endocrinology. You have the hypothalamus, you have the pituitary, and then you have many verticals come out from that. Some of the rules, for example, there are some organs which follow positive feedback, but mostly they follow a definite mechanism. We see a similar thing occurring in aging. Once we have these agiotypes in mind, we can create the markers, and they can be phenotypic. Of course, chronological is there. They can be phenotypic, they can be genotypic, and they might be simple metabolic. Let me add one marker which I learned about recently. We speak of testosterone, but what is the counterfoil to testosterone? Our colleagues in sports medicine assess testosterone cortisol ratio. Testosterone levels come down with age. Cortisol levels remain the same, but it's not a smooth decline or a smooth straight line. There are so many temporary factors, short-term factors, which modulate cortisol and testosterone. So if you have a high testosterone to cortisol ratio, it might actually mean social aggression. It might mean overtraining, overexertion. And for an elite athlete, it can actually backfire. So this is another thing we should work upon in aging. Instead of working only upon serum cortisol, instead of working only upon adrenal biomarkers, we might want to see a ratio or see a mix and match of these to see how the endocrine system is aging. But all that is fine. Dr. Meenakshi and Dr. Rakesh have helped us a lot. But Nitin, the final question from the audience will be, I know I am aging. I do not need any genotype or phenotype. So my calendar is telling me I'm aging. My psychology tells me I'm aging. And the social society, the society I am in, the social environment tells me I'm aging. Even if I don't want to be reminded, earlier when I was a doctor, people would say bhaiya to me, or they would say bhai sahab. Then they began saying uncle. Now children come in and say, Dadaji, how are you? Please take care of my mummy. So how do we manage all this? How do we manage aging, and how do we age in a healthy manner?
Thank you, sir, for that question and setting the stage so well. Thank you, Professor Sahai and Professor Dhar, for really lining out the evaluation aspect and making us understand what aging is. And thanks, Team IDEC, for having me here. And over the next 7 to 8 minutes, I will try and summarize what are the therapeutic options that we have for retarding aging and what can be done. And maybe the first thing that I'd really like to emphasize, which Professor Dhar mentioned in her talk, was that for aging, also we have to think of a person-centric approach. It's not that one size fits all. Today, we do talk of person-centric approach when we talk of obesity, when we talk of diabetes. But in this very well-written editorial, which alluded to the MESA study, the multi-ethnic study of atherosclerosis, very nicely tailored out as to why our vascular aging process is going to be different for every person that we see. It's not that low calories is good for everyone. There might be somebody who's very pale, may actually need more calories. It's not that, you know, estrogen is the solution for every woman and testosterone for every man. And we have to do a person-centric approach. And yes, we do have three-pronged therapeutic advances that we can use for retarding aging. Yes, we talk of dietary changes, we talk of physical activity, we talk of medications, and let's talk of each of them very briefly. So when we talk of dietary changes, I think the maximum evidence that stands out from literature is with respect to calorie restriction. On the slide, we see how by restricting calories, at least we can definitely improve the metabolic aspects of the person. But at the same time, we are also probably not hampering the cognition, the bone density, the sarcopenia. And that also is good, because if you're looking at somebody who's on a hypercaloric diet, all of these things are going to be worsening. So yes, low calorie is helpful. When you look at the hardcore evidence, and this is an evidence-based masterclass that we are in today, there are a lot of papers, and calorie restriction has helped not only in humans, probably from each and every species, from an earthworm to an primate, and even human studies. And if there was one study that I really wanted to say with respect to the evidence, is a series of analysis from the calorie study. Now, there are about 64 papers published from this study, and this one particular paper is just a small short analysis follow-up for 2 years, how the biological age can reduce by calorie restriction alone. So yes, calorie restriction is one way in which we can remain younger. We don't overeat, we eat less. But at the same time, I think it's very, very important that we balance this restriction. It shouldn't be that we restrict too much and become very frail. And that really comes, what really stands out in this calorie restriction is the protein supplementation should not be compromised. This is something which is very, very important in the South Asian population. This is a recent consensus paper that was published from our group. And we've seen that, yes, North, South, West, or East Indian, we all consume grossly inadequate protein. And this is something that needs to be addressed. So even though we are talking of calorie restriction, our diet prescription should emphasize on adequate protein. But is there something that we can just take it as a pill or an injection or a tablet, which can help us reduce calories? And this is what is called as calorie restriction mimetics. And this is an interesting article published in ITM by Dr. Kalra and team in 2018. And maybe if I was to choose one drug out of this, which is probably the best in reducing the appetite, I would probably pick up the GLP-1 RAs and we'll look at the effect of different drugs with respect to GLP-1 RAs. I think semaglutide, which is shortly going to be launched in India, is probably one of the drugs that can really help. So there are calorie mimetics. So in short, I've mentioned, yes, calorie restriction helps retard aging, but we do not compromise on protein. We can use even drugs to reduce our appetite. What about physical activity? And physical activity, again, there are two types. There are types wherein we talk of acute exercise of effects and the chronic exercise effects. When you talk in terms of aging, the acute exercise probably increases mood, probably improves the feeling of well-being. But really, the cognitive function is small, or it's debated. But what is really, really helpful is the chronic aerobic exercise. So slow and steady wins the race. So it is not about doing 5 kilometers walk today and nothing for the rest of the week. It's probably that daily 30, 40 minutes of exercise that is helpful for aging. Again, when you look at the evidence and the literature, it's not that we talk of just directly going on to high-end exercises, but first we talk of flexibility, then we make sure the balance is okay, and then aerobic and resistance exercise. It's a step ladder approach. There are several mechanisms described how exercise can improve aging. When you look at the evidence, yes, there are trials, randomized clinical trials, which have shown that yes, exercise can help. There are trials which are in process and in process of development. But it's not only about the aging, and this is another important aspect, that how exercise can help in aging is by improving cognition. And in this study, they have shown how this can really improve the neurodegenerative aspect of aging as well. Like I mentioned, for calorie, are there exercise mimetics? And I'm sure all of us would wish to just pop in a pill and say that we are done for the exercise of the day. Yes, exercise mimetics are also described. If there's one drug that I would like to pick up on this table, I would say probably SGLT2 inhibitors most closely resemble. Usually, if I want to lose calories, I would go to the gym and run for 1 hour. But what if I just take this pill and go to the washroom and lose 100 calories in the urine by passing out glucose? So probably there is a role. At this point, we do not have evidence whether this retards aging or not, but this is an area of research. And third, coming on to medications, and in medications, as was mentioned about the endocrine theory, yes, again, I would say it's important to choose your right patient. Definitely, they're talking about estrogen replacement. Yesterday in the OPD, I had one patient who had a pituitary lesion, and she's been on follow-up with panhypopituitarism, and she's taking her thyroxine and cortisol regularly. But she said, "Doctor, I'm not taking my tablet because I don't want the menstrual cycles." They're not realizing that hormonal pill is just not for menstrual cycles alone, and there's so much of metabolic benefit with respect to bone, with respect to the cardiovascular metabolic benefits, and that's just something important. What I would say is, yes, we have to see whether our patient actually would benefit as compared to the risk. Looking at breast cancer, thromboembolic events, if those aspects are less, earlier menopause, yes, that would be one answer. Similarly, in men, we talk of late onset hypogonadism, and that is again something that is grossly underdiagnosed and grossly undertreated. Again, getting the patient to speak about this, an elderly male, and using the appropriate treatment if required. If they have symptoms, if they have biochemical deficiency, treating is important. So apart from hormones, what else? Metformin, which was talked about how it's evolved over the last century or so. Maybe somewhere around 2000s, we started talking about metformin and its impact on the lifespan. We talked about these pathways in the previous two talks, the AMPK pathway, and how this is promoted by metformin. But what is the current research on metformin with respect to aging? And what they have said is that in the human trials, it doesn't help everyone. There are responders, there are not responders, and again emphasizes the fact that probably we would need to tailor it and find a personalized way. Once we have more research in future, we should be able to predict, yes, metformin is a good anti-aging therapy for this person, but may not be for that person. And research is still underway on that. Talking about another drug, this is resveratrol, and I'm sure Dr. Neeta is here, and maybe about 15 or 16 years ago, we were on a large clinical trial on this drug for diabetes, but I think this is the drug which talks about the French paradox, the wine that is helpful in reducing the cardiometabolic effects in the French people. Several mechanisms described, again, known and shown to have reduction in several aging-related parameters. This is another drug. And there are several other drugs which are there in the pipeline. As of now, there isn't really a big consensus guideline to say that, yes, this drug is better than that drug, whether this has to be used for aging. But there is, this is an area of ongoing research, a lot of interest. And I would just summarize and say, yes, so we've learned about different pathways, but there's good evidence for hypocaloric diet, high protein diet that is helpful in retarding aging. We talk about exercise. It's not acute exercise, it's the chronic aerobic exercise, which is more useful. Drugs, again, person-centric, in whom you have to use the hormones, where you use metformin, where you use the newer drugs. And ultimately, yes, there's a genetic underplay as well. I'll stop here. I'm happy to take questions. Thank you.
Dr. Nitin, that was nice. So we learned that there are different aspects of aging: metabolic, hepatorenal, immune. We can add endocrine to it. We then learned that you have different biomarkers. These biomarkers may be related to the chromosomes. They may be genotypic, they may be phenotypic, they may be metabolic. And we don't have any single biomarker. But then the human body is actually too complex to compressed into one particular marker. So you have different biomarkers all connected. And then the best part is we learned that we can actually improve things. If we want to prevent aging, all we have to do is to restrict our calories, do some exercise, and take a few drugs. Is that right, Dr. Nitin?
Yes, probably.
How nice, how simple. But let's move on. We have many questions from the audience. So from Dr. Rakesh, for Dr. Rakesh, you spoke about biomarkers. One biomarker can be serum testosterone. So should I do a serum testosterone in every aging man or only in some? And if so, what are the caveats? Should I do it in the morning, in the evening, at night? Should it be fasting? Should it be after a meal?
Yeah, I think you brought out the importance of testosterone measurement. And I mean, although we cannot recommend at this point of time that it should be done for every aging man, but I think it is an important parameter that can be used. What we should know is when we should do it. As you said, when should it be done? It should be done early in the morning, and you need to take a fasting sample. These are two important caveats that that we should keep in mind. And when measuring the testosterone, it's best to measure the total testosterone rather than relying on the free testosterone levels, because many of the assays are not very reliable in terms of measuring the free testosterone. So measuring the total testosterone would be a better marker, and doing it early in the morning.
Dr. Meenakshi, a question for you. What is the commonest agiotype that you encounter in the OPD?
I think we see a mix of them, because till the time the patient reaches us, I think the most common type is the renal ones, which we come across here in our OPDs, because of the underlying comorbidities, especially diabetes, which is increasing in so much, has a high, prevalence in our country now. So maybe the people are getting vascular. Actually, the basic of these angiotypes is a vascular aging, and vascular aging. The main reason is the uncontrolled diabetes. So mainly we see the renal ones are the most important ones which we come across. Young patients with an deranged, highly deranged KFTs. So I should say in my practice, at least I can't talk about the whole India, but at least in my practice, what we see is the renal agers are more common here.
That is true, and there is a differential also between morbidity and mortality.
So your voice is breaking.
Yeah, morbidity for people entering the OPD. Dr. Nilesh, the question.
Yeah, my question was, I was actually hoping that Nitin is going to tell me you can take this pill, ma'am, and that is anti-aging, but that didn't happen. He told me to do all kinds of difficult things. Now, the other thing I want to ask is, when do we actually start looking for actually instituting any anti-aging therapy? I know we start aging the minute we are born, but when do you actually look for the biomarkers, or when do we actually intervene to get the benefit?
So maybe I'll start, but we can have input from Professor Dhar, who is a geriatrician. But as ma'am said, yes, we do start aging from birth. There are recommendations to say that we start aging more at 30, but in women, we see a sharp decline after menopause with respect to a lot of aging parameters. I wouldn't say there's a consensus as to when we have to start instituting therapy for aging at a particular age, but probably I would say in women, menopause is definitely a strong indicator. When patients come to us and start asking those questions, maybe it should be earlier, but Professor Dhar, what is your take on this?
Yes, sir. Thank you, Dr. Nitin. I think I go with the Professor Sander that identify the ageotype and then institute the therapy. Because unless and until we don't identify what is the ageotype, then only we can institute the therapy. Then when to institute the therapy is that once the patient starts the signs and symptoms of an aging. So when the person starts, his chronological age is not correlating with his biological age. That is the time probably when we need to look into the patient and see which type of ageotype is that person belongs to, and then only institute the therapy accordingly. It has to be personalized to the need of the patient. And I think probably that is the reason, as you told Dr. Nitin, that metformin doesn't work for all the patients in delaying aging. Maybe that is the reason for that.
It should be, we should incorporate anti-aging into our OPD communication. So let us say you're writing a statin or maybe an ACE inhibitor or an ARB. There are many ways of motivating the patient to take that, but one method might be ये आपकी खून की नसों को जवान रखेगा, ये आपकी खून की नसों को बुजुर्ग नहीं होने देगा. So if we incorporate this, and of course it is not going to work for an 18-year-old or a 25-year-old. Dr. Mithun just spoke about the fact he was speaking to a type 1 diabetic. When he spoke about chronic complications, the boy did not get engaged. But the moment he spoke about sexual dysfunction in diabetes, then the boy became a willing partner in his own diabetes care. So if there is an indication like that, you do that. And I think we should explore more agiotypes as well. One agiotype is that of memory loss. So many people coming in and saying that I have begun to forget. So, Dr. Meenakshi, any hints for that? How do we handle that? It's not dementia, it's personality dementia, it's just forgetfulness.
Yeah, one is that forgetfulness is it's usually don't say that it's a part of aging, but there are some things which we say that is compatible with that of an aging of a person. We have some screening tests which give us the idea whether really the patient is going into forgetfulness or is going into dementia, or it is just a part of an aging. So and that the last slide which I showed is that to prevent that keep your mind active and keep on learning. That is how we will prevent this part of forgetfulness and dementia.
So that is one good take home. I know that as senior citizens, we take 1 minute extra. And a question for Dr. Nitin Kapoor. Dr. Nitin, I heard that you are married in Haryana. Is that right?
Yeah, my wife is from Haryana. That's right.
So, two questions for you. What is the role of turmeric in preventing aging in Haryana. I mean, so for those who are not from Haryana, turmeric is a treatment for everything in our state. For everything, the treatment is turmeric milk. So you do not need to go to Alexa or to Google Assistant to find out what to get treated. You have a pain in the head, the treatment is turmeric milk. You have a pain in the stomach or in the foot, the treatment, or memory loss, the treatment is turmeric. So, but what is the mechanism of action of turmeric? Has the Western world finally woken up to Haryanvi wisdom?
I think yes, definitely they have woken up. Turmeric is actually not bad. So when you look at the active ingredient, which is curcumin, which is essentially an antioxidant, and Professor Dhar showed about the role of senescent cells and the oxidative stress that develops and accumulates and causes aging. So that's where turmeric probably helps as an antioxidant. So that's what it is.
So it's a polyphenol. From my side, if we can just request Dr. Rakesh, Dr. Meenakshi, just one take home. Dr. Rakesh, please.
Yeah, I think the best take home was that we should keep in mind that we need to assess aging soon. I mean, not leave it for for people to ask us. And also the other take home was, the very important thing was that when you said about the aging and the using it in clinical practice, I find that using it for starting antihypertensives in patients with diabetes, where they don't want to accept that they've got hypertension, I tell them that this pill is going to actually help you keep your vessels from becoming stiff. And that's what actually makes them start taking the antihypertensives. So I think that is a very important take home I would like to give to everybody. Yeah.
Thank you. Professor Dhar, please.
Yes, I learned a lot from this presentation, that especially the practical aspect of it is that how you motivate your patients to be compliant with the drugs. Because if you tell them that this will retard your aging, definitely it's going to make a difference to them, and they're definitely going to take it.
And we add the which comes from Dr. Kapoor's the in-laws. Anjali. Whoever chose this topic, and I know it is Dr. Neeta and Dr. Anjali, it was a wonderful topic. We all had a lot.
Thank you so much, sir. As much as I would like this discussion to go on and not stop it, as much as I would not want aging to go on and stop it. But unfortunately, we will end this session. Thank you so much, Kalra sir, Meenakshi ma'am, Dr. Sahai sir, and Dr. Nitin for this wonderful discussion. We look forward to this topic in future meetings also.